Many thanks to BIOS for giving us this opportunity to talk about foot and ankle trauma. So the aim is we are going to discuss a few cases. I have the pleasure, I have an esteemed faculty panel members with me here. Karthik Hariharan, or Harry, very good friend, and great educator, past president of BOFAS, and Rajesh Kakwani, again, fantastic educator and has served in the scientific and EdCom committees of BOFAS. They are here with me. Mandeep Dhillon unfortunately had some personal family matters, so he can't be with us. So we are going to kick off the session by putting the first case. And I'm going to, so this is a 38 years old female who sustained this injury when she was holidaying abroad. And these are her initial x-rays. So might be asking my colleagues how you would plan management. Rajesh, what would you recommend?
Okay, this is definitely one not to be given to the registrar to just fire in 2 syndesmotic screws. This is a very significant injury, and this has to be done. I personally prefer doing a CT scan for these to ascertain there's no intra-articular damage, and then do an open reduction. I protect the superficial peroneal nerve, open it anteriorly. Many times there is a AITFL, which is folded into the syndesmosis, which has to be fished out, anatomically reduce the syndesmosis, get the fibula length back to normal, and then put syndesmotic screws.
Okay, thank you. Yeah, so I'm not sure if a CT scan was done or not, but this is what was done. And these are the obviously intraoperative images. What are your thoughts, Rajesh, about that?
This looks okay. There's no talar shift. The syndesmosis seems to be reduced, but this is only an AP view. The fibula may be slightly short. I may need to compare it to the opposite side, but overall, it looks to be nicely reduced.
Thank you. Now, this is her X-ray 4 months down the line. And we can see the fibular fracture has not healed. There was obviously communicated a spike. And there might be another view. We have another view. So obviously, this is what it is. So now this is the situation, 38-year-old female who sustained this injury 4 months back, and she's quite chubby. Harry, how are you going to tackle that?
Okay, if I can rewind a little bit, I think if you get this patient in the evening, you have a registrar who's looking at it. There is the current vogue due to the lack of green pathway theatres, etc., to say, look, we can put this in a plaster and bring them to a fracture clinic in a week's time. And I think that is absolute no at this present moment. This, as you have rightly said, was a significant injury, and I think care needs to be taken to make sure there isn't a small posterior malleolar fracture. And I would agree with Rajesh that this ideally could be CT scanned, although it's not imperative. But for the general orthopedic surgeon who is seeing this patient, they must recognize that this is a very significant pronation external rotation injury with a huge intraosseous tear and a significant risk of intra-articular injury. Now that we've reached this stage, the presumption is that there is, you said that there was a non-union at the fibular fracture, so it is quite clear that there is a talar shift. The syndesmosis is opened up quite significantly, and it is quite clear that the ankle is unstable still. There is obvious fibular shortening. If you compare it to the original X-ray, the fibula has shortened, presumably at the non-union site. So at this stage, again, I think it might be useful to get a CT scan, and I would probably get a CT at this stage, firstly to ascertain whether there is a fracture in the incisura itself. Sometimes that can block it, but as Rajesh said, that there might be the AITFL, which is stuck inside. The second bit is one was recognized. This is 3 months down the line. The medial side is going to be full of gubbins. There's going to be a lot of fibrous tissue and scarring. So clearly this requires a revision. And once you have decided that you take the screws out, you'll have to check to see if the fibula is short at the non-union site, and one may require to fix it. But the most important thing is you need to clear the medial side of fibrous tissue and scarring and open up the syndesmosis to ensure that you reduce the fibula into the incisura anatomically to get the rotation right. One of the problems here is I think the fibula is slightly externally rotated. So if you looked at these screws on the lateral view, it looks like the screws are at the posterior edge of the fibula. I may be wrong in that interpretation, but that's what it looks like. And if you put it posteriorly, the fibula will automatically, it'll be compressed in the back and it will not be compressed in the front. And I think the external rotation needs to be corrected. And that could be one of the reasons why you need to fix the non-union to get your rotation right. And I usually put in screws which are quadricortical. I tend to engage the far cortex of the tibia in addition, which I think will afford it extra stability. And
Thank you so much. So yes, I mean, as you said, this had to be revised. It wasn't an easy revision due to obviously 4 months down the line, chunky patient, and had to open the medial side to clear it and then reduce the syndesmosis under vision. And
sorry, can I just interrupt there? If you looked at your X-ray now, it looks like the syndesmosis screws are more centrally positioned on the fibula too, and I think that makes an important difference in concentric reduction of the syndesmosis, so that you're not pushing the posterior side too hard and opening up the front. And I think that's an important consideration too.
Thank you. So just to summarize, the take-home messages from this case are that it's potentially difficult case and should be operated upon. There should be a senior supervision. The syndesmosis should be reduced as accurately as possible. Get a CT scan if you can, and then open reduction of syndesmosis to make sure, or at least make sure that the reduction is anatomical as much as possible. Placement of syndesmotic screws, 4 cortices, if possible, if you're using 3.5. And then fibular fracture, that is debatable, isn't it? People might argue that whether you need to fix the fibular fracture in the first place or not, then people can go either way. And either approach is right, I would have thought. Would you agree?
Yes, yeah, I would certainly agree with that.
Okay. Thank you so much. So we now move to our next case. And this is 84 years old gentleman who has got multiple medical comorbidities, blood pressure, ischemic heart disease, type 2 diabetes, and it's a bimalleolar fracture. And it was decided to treat this injury conservatively using a total contact cast, which was applied in theater. And this is what the reduction looks like. I think fair to say that reduction looks pretty good here. The plaster itself, maybe I'm not sure, but yeah, I mean, overall, I can't criticize this management. Would you support this? This is how you could have treated somebody with medical comorbidities, 84-year-old, non-surgically in a total contact cast? Reasonable thing to do or not?
Diabetes is the magic word here. We all recognize that diabetics have innumerable problems, both when it comes to wound healing, the precipitation of Charcot in an individual of this nature. There is no criticism of putting a TCC on, and indeed, as you know, there is a study going on now about TCCs in ankle fractures, trying to treat them conservatively. Again, I deal with diabetics in the way I deal with non-diabetics, but I take extra precautions. So if this patient came to me, I would say this is a displaced fracture. If he hasn't got any peripheral ischemia and he hasn't got previous ulcers, etc., I might have considered fixing this using locked plates and following the same principles of osteocentesis and periarticular fracture fixation, anatomically reduce the articular surface and put a robust form of fixation. What I would do differently is probably to keep them in a plaster for much longer, double the time of non-weight bearing, and take the usual precautions and watch out very carefully for Charcot coming on the scene, which with all of its attendant problems. If you're talking about this particular instance, the plasters holding the fractured complex just about, okay? There's already the beginnings of a migration of the medial malleolus. And so if I were going to be treating this, I would see this patient on a weekly basis, possibly x-ray them on a weekly basis too, just to ensure that the plaster is actually doing its job and they're not slowly subluxing inside the plaster, which is the worst of both worlds because the medial skin is under tension. You'd start to get immediate problems with it.
I agree, Harry. As you mentioned, the current trial is going on for younger patients, but I was part of the original AIM trial, and I did treat a lot of patients. And in the AIM trial, I think it was recommended that these patients should have sequential X-rays every week for the first 3 weeks. Yeah. And unfortunately, what happened that this patient, the follow-up plan wasn't great, and then 6 weeks down the line, they were seen in the clinic with X-rays. Obviously, things had become like that. So, Rajesh, what are your thoughts now at this stage?
Okay, now this is becoming challenging at this stage. First of all, we need to know the soft tissues. Are they still okay? Because there is a tendency for this to progressively drift laterally if we don't do something about it. So if the soft tissues are all right, then this should be fixed. And in my hands, if the patient has poor mobility with comorbidities, the best option would be to have a hindfoot nail to realign the ankle.
Can I just ask, would you have chosen hindfoot nail in the first instance when you saw the initial X-rays? If I just go back, can I just poll between us? So, Rajesh, how would you have treated in the first instance? He had diabetes but didn't have any neuropathy and had medical issues. So in the first instance, your choice would have been to treat it in plaster, TCC, or hindfoot nail, or ORIF?
Frankly speaking, in diabetics, I'm a bit more aggressive. I tend to treat them with double the amount of internal fixation. But if the soft tissues are not permeable, then I would have treated it in total contact cast, but kept a very, very close eye on it, as Harry said.
Put me on, I got a question.
Harry, in the first instance, you would have fixed it, or?
Yes. I think if the biological environment was satisfactory, the patient was optimized for his diabetes, he was a reasonably reliable, compliant patient, I would have probably done a fibula pro tibia fixation using a locked plate on the lateral side, connecting fixing the fibula to the tibia with 3 screws, and I would have fixed the medial malleolus with a couple of screws. That would have been my optimal way. As I said, I really don't differentiate between diabetics and non-diabetics as long as the vascularity and the patient profile would allow it. Okay. I would certainly consider, in somebody who might think we've only got one bite of the cherry, the patient is not totally reliable, and the omens are poor, then I would probably have considered a nail as a primary form of treatment.
Hi, guys. There's a question from the audience, if I may, Manish.
Yes, Yogesh, go ahead, please.
Okay, so the Abhishek Arora wants to know, would there be any role of a fibular nail in this case, and what's the view of the faculty?
I personally prefer to do a fibula pro tibia type of plating, which is a much, much more stable fixation in this age. Yes, fibular nail is possible, but I find it very difficult to perfectly reduce the ankle with a fibular nail.
Yeah, I would concur with that, Yogesh. I think fibular nail has got the potential to cut out. The rotational stability is poor, and it would be nothing compared to a good fibular protibia fixation.
I mean,
Make it 3. I'm not a fan of fibular nail either.
But that makes 4 of us anyway. But what I'm going to do is I'm just going to keep a watch on the question from the delegates, and I'll just convey it to you. Just because you are discussing, you won't have a time to look at those. So
they're not coming to me anyway. No, thank you, Rajesh. Sure. So 6 weeks down the line, this is where we were, and then as you've said, I don't think there were. I mean, I thought that one bite at cherry, and I did a hindfoot nail for him, and I think the patient did reasonably well. Well, until 6 months. So we now move to next case, which is not an ankle. Now, this is a patient which very kindly Harry has submitted. So Harry, over to you.
Okay, this is a young man who presented to the accident and emergency department having fallen down a ladder, and whilst he was coming down, he landed heavily on one of the rungs of the ladder, which resulted in a hyperdorsiflexion injury to the ankle, and he presented to accident and emergency with this. There's quite clearly a profile anomaly at the back of the heel. The skin looks somewhat dodgy and ischemic, and he had X-rays done, and that was what he had. Perhaps I'll open it out. Perhaps Rajesh, you might want to comment on what you felt.
Yeah, this is one of the rare orthopedic emergencies. This has to be treated urgently. If that skin is allowed to stay overnight, that skin can easily necrose. And then covering that area is a big nightmare. So these are one of the few patients where I would, like a compartment syndrome, I would go in whatever time the patient comes in and reduce that fracture to detension that skin.
Can I then ask then if there isn't a foot and ankle surgeon on call, what would a general orthopedic surgeon do in this circumstance? I mean, how is he going to, he may not particularly be keen to open a calcaneal fracture at 10 o'clock at night to fix it. What would your thoughts be on that?
Okay, so in my case, I have gone in as a sort of have been rung by my colleague
to
come and fix this, which I have gone in because it's so much more easier to fix it primarily when it happens rather than delayed.
But you're a nice guy, Rajesh. Well, not all foot and ankle surgeons are nice guys.
Sometimes when you plantar flex the foot significantly, that skin can have some time to survive and be fixed overnight, but not always. So try to put the foot in plantar flexion, see what happens to that skin. If it's still white, call your foot and ankle surgeon or trauma surgeon.
No, I completely agree. What about you, Manish?
No, I think that's very, very sensible what Rajesh has just described. I mean, I personally agree that on a practical front, it's difficult to, take this patient to theater at midnight, and especially if you're a general orthopedic surgeon, better to detension the skin and put them in plaster, wait till morning. But yes, don't wait it for too long. Just try to do it ASAP first thing in the morning.
I think I agree with Rajesh. This patient should have been put into an equinus plaster to at least look to see if that will detension the skin a little bit. Unfortunately, the patient was sent home to come to the fracture clinic the following week. But luckily, the patient was in so much pain. He came back a few hours later saying, look, I can't bear the pain, and happened to see one of the senior orthopedic trainees who recognized the danger of this. And he was taken to theater. I took him to theater 8 o'clock in the morning. We did, as you can see, the skin is still a bit dodgy, but I did do an extended lateral approach because this is how I fix them. I use screws to push the tuberosity fragment back in, but they never stay. They are very often cut out. So I use a tension band wiring system on the lateral side to try and get added purchase, and I use the wires going through the screws. So it's not a true tension banding effect, but it's very effective in keeping the fracture there. This is one of the Bristol Group techniques, which I've found very useful in this fracture. But the lesson is never I've got horror stories where I've had, skin grafts and infections into the os calcis, and this is an interesting fracture in diabetics and in the elderly, because it often starts off as a stress fracture and one fine day it pulls off, and that is the danger in patients like that, where there's been a slow fracture progression. You often find that they tend to miss. And I have actually got a patient who was admitted into hospital because they thought he had a diabetic ulcer in the back of the heel. This fracture was not recognized until they got an X-ray. So the lesson is, watch out. This is a genuine, serious orthopedic emergency and has to be tackled in that fashion.
Absolutely. Yeah. And this is Achilles, isn't it? Achilles pulls the proximal fragment, and that's what there's nothing. You have to fix this fracture. I don't think you can argue that you would get away without fixation. Yeah. Yogesh, are there any questions from the floor, or we move on to our next case?
No, at the moment there aren't any questions. But just one little comment, if I may.
Yeah, sure.
Well, this is a very, very good technique Karthik has used, but I also got limited experience of using the tightrope on it. So remember that is also a useful device to consider in case of this sort of fractures.
That's very interesting. I've never used tightrope there.
No, I used it. It worked for me. So
excellent. Okay. Harry, Rajesh, have you used tightrope for this injury?
I have used cannulated screws, but I have used 6.5 cannulated screws. The only two things I would like to say is they need to engage the plantar cortex, otherwise it will pull off. So if you're using the screws, make sure they are engaging the plantar cortex.
Correct.
And very rarely will you be able to close reduce it, because that skin gets puckered into the fracture site.
Yeah.
So more often than not, you'll have to open reduce it. And I personally prefer screws. I have no personal experience with tightrope.
Neither have I, sorry.
Yeah, no, same. So in interest of time, we'll move to our next case. The more we can do, the better it is. I think we still have time. So the next case, let's see what this one is. I think this is one of yours, Rajesh.
Yeah, so this is, again, a 21-year-old lady who's quite large, had a lot of alcohol, dancing on the table, fell off with this injury. Now, as you can see, it looks like a trimalleolar fracture with a high fibular fracture, a bit similar to the Manisha's case, first one, but this has an additional component of malleolar fractures. This highlights my point of these fractures need a CT scan. Can we go to the next slide, please? Okay, so initially you can reduce it, which can give you an impression that this seems to be a very benign fracture now, where it's perfectly reduced, high fibula, and a small posterior malleolus. But if we go to the next slide, it will highlight how much articular damage this patient can have. So this patient has got a lot of comminution of the medial malleolar fragment. The posterior malleolus is also comminuted, although after reduction, the syndesmosis has been reduced quite nicely. So the take home for this case would be, in these patients with posterior malleolar fractures or syndesmotic injuries, do a CT scan. You'll be surprised about the amount of articular damage that these patients will have. Does Karthik or Manish have any comments, or else we can go to the management?
No comments.
So far, what you've said, Rajesh, I agree completely. That's how it should be managed.
I think we've entered a new era, really, once the Aintree classification has come through, which highlights the anatomy, the pathophysiology of posterior malleolar fractures, and also offers an algorithm for treatment. So it's well worth taking a peek at the Aintree classification. I think the importance is to recognize, as Rajesh said, you have to recognize that this is a serious injury, and we have to get it absolutely right. And perhaps it's quite useful to understand rather than using the Weber classification, which doesn't really have anything to say either about the soft tissues or the posterior malleolus. It's useful to use something like the Lager-Henson, where an appreciation, even for the general orthopedic surgeon at the entry point in the ED, if they can understand the mechanisms, then they would recognize how severe a fracture is and how unstable it is.
Absolutely. Now, Rajesh, you've done a fantastic job, but from again, from the point of view of general orthopedic surgeons, especially at DGH, where they might not have foot and ankle expertise, what would your message that familiarize yourself with the posterolateral approach?
Definitely so. Familiarize you with your posterolateral approach. It's very, very simple. It's the fear of the unknown. There's only a sural nerve which can be easily identified and retracted. And then there is nothing else between you and the bone. So, and the other thing I would like to highlight is the posterior malleolar fracture is very, very, very similar to a volar Barton's fracture of the wrist. You would never fix a volar Barton's fracture with a screws from dorsal to palmar. Then why would you like to do something different for a posterior malleolus? It is begging for a buttress plate, and it stabilizes beautifully well with a buttress plate.
And then once you've done it, you don't need syndesmotic screws.
Yes, most often the syndesmosis will become stable because by fixing the posterior malleolus, you're stabilizing the PITFL. So to assess the syndesmosis, and in many cases, the syndesmosis becomes stable after fixing the posterior malleolus.
Okay, I'm going to ask both you and Harry, what's your position? Do you put your position prone or and then turn them supine, or do you put them in a recovery position?
If I'm going to use a posterolateral approach, I use a slight variation because I go very close to the tendon. I struggle with the idea that if I use a posterolateral approach and I have to fix the fibula, it makes for elevating and stripping a very large soft tissue envelope. So I use an incision which is paratendinous. So I put them on their lateral side and then flick them over to a supine position to fix the medial malleolus. But very often I've tended to use the posteromedial approach, which again, I find very much more central, and I'm able to fix both lateral and medial components of any comminuted posterior malleolar fracture. For those, I tend to go prone, and I can fix the medial malleolus medially, and I can fix the lateral malleolus laterally. So I use a 3-incision approach to minimize the amount of stripping. That's just me. There are many ways to skin a cat, and you can do it where you find it comfortable. My interest, rather than the approach itself, is what is the order of fixation that you guys do? Do you fix the lateral first, the medial first, the posterior first? How do you work it?
So I go for the lateral malleolus first, then I go for the posterior mal, and then I go for medial malleolus.
What about you, Rajesh?
I do the same. I actually do a posterolateral approach. Reduce the fibula, make sure the posterior malleolus is also reduced, then fix the fibula first, then the posterior malleolus, and then the medial side.
Yeah.
Okay. Interesting, because I tend to do it the other way.
As you said, there are so many ways to skin the cat.
Clearly, yeah.
Yogesh, do we have any other question?
Yeah.
Or we can.
Yeah,
okay, go on then.
Sorry, we got 2 questions on this case, and then there is a 1 or 2 from the previous one. But on this one, there is a question from Mukund Deglurkar and Satish Jainapadi. Can you just expand on the syndesmotic fixation in case? Because somebody says, is there a syndesmotic fixation there with a screw or tight rope, or is not? Why is it not? So Rajesh, could you kindly enlighten on that?
Okay, so this one is one of the cases where I fixed the posterior malleolus and the syndesmosis was still opening up, which happens in around 20%. So if you see carefully, there's a tight rope across it, which is stabilizing the syndesmosis. But in these cases, you use tight rope only if you fix the fibula, because your fibular plate will then restore the length alignment rotation of the fibula, and the tight rope is just for the rotational stability.
So just following up on that, Yogesh, is if you've reduced the posterior malleolus and fixed it, you've reduced all of the other components of the fracture, it is still imperative that you check both in the sagittal and in the coronal planes. You check the stability of the syndesmosis, because if you had a comminuted posterior malleolar fracture, some components of the PITFL might still be hanging around and loose fragments, attached to loose fragments, and you may have instability. So the important thing is, after you've fixed it, you recheck the stability of the syndesmosis. You cannot simply presume that just because you've fixed the posterior malleolus that it's all stable and fine. You need to recheck it. It's really, really important.
Yeah,
because the initial messages that came through was once you fix the posterior malleolus, it's all going to be fine. And as Rajesh correctly pointed out, a fifth of these patients will continue to have a degree of instability.
Yeah, I think that's why those questions I highlighted, because I know this is going to highlight that important point which we needed to make everybody aware of. So that's why those questions. There is one more question about the medial side. The plate which you use is like an L plate. So they are saying that is there any advice on using a simple plates or any specific medial malleolar plates for the medial side?
Okay, so here in this case, it's a vertical shear type of a fracture of the medial malleolus. So that's why any form of buttress plate will be fine. This contoured the best in this particular case, where I could engage and buttress all the fragments. But a 130 Wheeler plate, a T plate, or any hook plate will be sufficing as long as you use it in a buttress mode.
Thank you, Rajesh. Thank you.
Do we have time for one more case?
Yeah, we got 5 more minutes if you want to run the next case.
Okay, so actually this brings beautifully to the medial malleolus. So this is a case. This is a university student, 21-year-old student who again had this injury and had this fixation. And in the interest of time, this is what happened. So, Harry, what do you think about it?
It's a simple question going back to how you define the fracture. What is the mechanism of injury? And that's why you don't say this is a Weber B fracture and this is how you fix it. What is quite obvious is the alignment of the fracture line is possibly more sagittal than a routine fracture. We don't still know whether this was an unstable syndesmosis or not, because that hasn't been defined yet. So certainly you've got a significant disruption of the medial side. So it's a failure of the medial side with the inevitable consequence of talar rotation. So you've already got an incongruous joint there. You can see that the medial side is opened up. So there is potentially a syndesmotic disruption there. And you can see the alignment of this fracture now, which is almost vertical. So it's a front to back sagittal, and that is the correct fixation. That's what you need to do, because putting 2 screws in there is not perpendicular to the fracture line, and it will not hold the fracture. You need a buttress mode plate, which will not only compress medial to lateral, but will also buttress the fragment and prevent it from sliding up. And that's the lesson to be learned from this.
Thank you, Harry. Yeah, and we were having the discussion. So obviously, this case, you can use whichever plate, as Rajesh said. You can use 1/3 tubular. You don't need to use any specific fancy plate, and just a simple plate would suffice for a vertical medial malleolar fracture. Guys, I think our time is almost up. 4:15. We are 4:15, so bang on time. We have one more case, but in interest of time, I'm happy to hand over to the organizers. I think we are all done here. Thank you so much. Thank you so much, Rajesh. Thank you so much, Harry. And Yogesh, thank you for getting the audience involved.
Thank you very much. I think fascinating session. Amit is over to Amit.